Thank you. So I gave a presentation once where the person who introduced me said, this is Mark, he's here to talk about surveillance and statistics, it's going to be boring. So, which I loved, actually. I thought that was the best, one of the best introductions I've ever had. So certainly my presentation today is going to be a little, how should we say, drier than some of the previous presentations that we've heard today, just by nature of what we're doing. But so I'm an epidemiologist, and I use statistics and looking in data to look at how disease, in this case HIV, and other factors like behaviors, determinants are sort of distributed in society or in a population. And that's really what the focus of today is, where we're really looking to see how we can look at, sort of in one fell swoop, look at all of the data that we have at our disposal in terms of what's going on related to the HIV epidemic in gay men in British Columbia. So this graph is just sort of reflecting on where we are today in British Columbia. So clearly we've made great inroads in the province. So the orange line shows the number of new HIV diagnoses in the province every year. And so clearly it's dramatically decreased from the early days of the HIV epidemic. And more recently, we have seen a slow decline in the number of new HIV diagnoses in the province of British Columbia. Last year we had 289 new diagnoses, and that's the lowest number on record, and we've dropped below the Canadian rate for the first time. So when the Public Health Agency gives us some estimates in terms of the snapshot of who is living with HIV at a point in time, in this case for 2011, as well as what are the number of new infections, not new diagnoses, new infections. And what's clear when you look at both of these graphs is that what's shown in blue, the proportion of both new infections and people living with HIV in the province are disproportionately represented amongst men who have sex with men. So we are definitely the major proportion, or the major population that's most affected by HIV in the province. When we look at our new diagnosis data, looking at the more recent trends, the graph at the top in purple is the number of new diagnoses in men who have sex with men in the province. And so what we can see is that perhaps there's a suggestion of a slightly decreasing trend, but overall it's still pretty elevated and still fairly stable. We do see that's in contrast, and part of the reasons why we are seeing overall a decrease in the province is due to the decrease in new infections amongst people who use injection drugs, shown in green, which we've seen quite dramatically over the past few years. But amongst men who have sex with men, we haven't really seen substantial change. When we look at this by region, we see a very similar pattern. So most of the new diagnoses are in Vancouver, followed by Fraser and then the other health authorities. But again, it's fairly stable. We do see a sort of an uptick in diagnosis in the past couple of years in Vancouver Coastal, a little bit in Fraser, which may be related to some of the testing initiatives that have gone underway over the past few years. When we look, the Public Health Agency also, when they're coming up with their estimates for Canada, they look at estimates in different populations in different provinces. And so this is the Public Health Agency of Canada's estimate of the number of incident infections, so new infections every year in men who have sex with men. And so certainly looking at this, we know that the HIV epidemic started in men who have sex with men back in the late 80s, and then decreased to the lowest point in sort of the mid-90s, increased to the early 2000s, and has been relatively stable ever since. So this is kind of what is the incidence, which is underlying our diagnosis rates as well. And so I think it's encouraging that it's not increasing, it's discouraging it's not decreasing. I call this sort of a critical yet stable rate. When we compare British Columbia to other parts of Canada, we can see sort of variations on the same theme for the regions that have recently published data, seeing either some slight increases over time in Alberta, decreases in Quebec, stable trends in Ontario. And when we look globally, so when you look at Canada versus US, parts of Europe and Australia, all high-income developed countries with generally sort of thought to be somewhat comparable populations of gay men and other men who have sex with men, we see, again, very similar findings of stable, often increasing rates of new diagnoses. And so it's clear that in many of these regions that the trends are not changing for men who have sex with men, despite some changes in other populations, and that the incidence that we are seeing is enough to sustain and drive the epidemic. One of the most striking findings that we found when we've looked at our recent data in British Columbia is that there are differences by birth cohort or age, and that's sort of a theme that sort of has been emerging, I think, so far in the summit, if you were at the investigators meeting as well earlier today, thinking about differences by age. What we've done in our new diagnoses, you see that we've looked at 3 birth cohorts. So the first being men who are like in their 30s or under right now, so born between 1980 and 1999, where we've seen a gradually increasing rate or increasing trend in new diagnoses over time, and then men between between 30 and 50 years of age currently, sort of born between 1960 and 79 in purple, and men who are older 50, or above 50, born before 1960, and that's decreasing over time. And so to me, this is quite striking because it's clearly showing that there's generational differences, and I think probably the biggest explanation for this is just the natural life cycle, lifespan, because younger men are now becoming more sexually active during this time period, becoming more exposed to HIV, which would explain the increasing numbers. So you can think of this a little bit as younger men aging into and older men potentially aging out of the HIV epidemic. But clearly it's not just related to that. There's clear differences between these generations of men, most notably I think marked by the experience of the HIV epidemic with before HAART was introduced, where men who are currently in their 30s or under weren't really exposed to that. And then we also have the potential for thinking about what's the impact of that in older generations, where we have sort of the survivorship effect of people who are still alive today from that generation. So why we're here today, I mean, ultimately, if our goal in British Columbia is to decrease the number of new infections, in order to do that, we have to reduce the incidence amongst gay men. So we really feel it's time to take stock of recent trends and think what we know about factors that influence the HIV epidemic in gay men in British Columbia. Some of you know that Travis and I, Travis and I who have worked on this presentation, are collaborating with Perry Kendall, who's the provincial health officer for the province, and we're working on a report to describe trends in HIV amongst men who have sex with men in BC. And so this is the analysis of data that we're using to inform that report. And it's really, we see this today and sort of over the next little while we're working on that report, we're seeing this data as a springboard for discussions because we're really looking for your input as well in terms of what are the directions to further reduce the HIV incidence in gay men in British Columbia. To do this, we've really tried to come up with a snapshot of recent trends, and many thanks to Rick and Terry and Olivier for collaborating with us. So Travis and I have had access to the SexNow data and have been looking at historical trends over time. And again, it's one of the fantastic things in BC that we can do is to have this resource where we can look at trends over time amongst gay men in BC. So we've looked at the last 4 rounds of the survey, which were all done online, focusing on BC men, as well looking in a little bit more detail at 2011, so focusing on that. We've also drawn on the other data that we have access to, provincial surveillance data, as well as some treatment data provided by the Centre for Excellence. And our emphasis in looking at this is since we were struck by the impact of different birth cohorts, we're actually now we applied that same lens to looking at these data, as well as really wanting to have an understanding of how the data is distributed by different regions of the province. But before we get into that, I just want to talk a little bit about when we're thinking about this trend. So this, again, is sort of the trend of new diagnoses amongst men who have sex with men in British Columbia. When we're trying to, it's often hard when you have a stable trend, because if it's increasing or decreasing, it's somewhat easier to wrap your head around what might be factors that are driving that. But when it's stable, it's a little bit more complicated. So there are different scenarios. So one is this could be just related to things being completely in stasis, so there's nothing that's changing. So we're just kind of in a holding pattern. And it's true that there may be a combination of variables that are may not be changing. There can be sort of an upward influence on this trend as well, in terms of variables that are acting to increase incidence or increase diagnosis. And then these are potentially being opposed by factors that are exerting a downward trend. And so really I think it's a combination of all of these different kinds of factors that are resulting in the graph that we see, or the trend that we see overall in the province of British Columbia. I think this, I don't think, is a value that anyone here in the room doesn't agree with, but I think it's quite interesting in the sense that this is something that I'm seeing more and more in the published literature and amongst public health leaders globally, that when talking about HIV and gay men, that we definitely need to focus on more than behavior and more than factors right at that behavioral or individual level. And this is a quote that came from the Lancet series that was released this past summer in conjunction with AIDS 2012, which I think speaks to the importance of looking at other drivers, biological, couple, network level, community level drivers, as being essential to understand and to then, in fact, target if we're trying to affect HIV rates. So our model and how we approached this was really drawing on that and influenced on that influenced by that by trying deliberately to draw on these different drivers of the epidemic and think about what they are and what those influences might be. So when you think about it, so we sort of have this model where we're starting at the starting point is an HIV transmission event. So someone becomes infected with HIV, which is a passing of HIV from one man who's positive to one man who's not. Then when you sort of take one step out, you're looking at what are the factors, immediate factors related to that, and that includes what kind of behaviors, what networks are at that level that can influence whether someone is infected or not. And then you begin to gradually move out into looking at things at a community level, sort of parts of gay culture, parts of relationships, and then finally thinking more at that determinants level. And this is really the whole focus of the summit for the next 2 days, and that's a deliberate lens as well, thinking about social and structural determinants. So what we've done, when you think about it, I mean, there's probably a very, very long list of potential factors to look at and influences or drivers that could be affecting the HIV epidemic. So we've focused a little bit, focusing on those where we feel that there's substantial ground in terms of importance, also where we have data to look at them, as well as some of the conversations that we've been hearing in discussion with many of you about what your thoughts are related to this. But I am going to start from the structural and social and gradually work our way down to sort of the immediate or individual determinants. So first, when we look at social connectedness and social support, we heard in the investigators meeting this morning the importance of social support, and we looked at two things. So one is looking at the proportion of time that men spend with other gay guys, and certainly in the past there was a sense in the literature that this is an influence on people's behavior because of, for example, having access to information, community services, and being connected to a gay community. And I think we've already had some conversation about how clearly the community landscape or scene has shifted over time with the internet, lack of fewer gay spaces, those kinds of things. So I don't think this is surprising, and we do see that this is decreasing slightly over time. When we look around the province, and this, I'll just spend a little time explaining this graph because you'll see the same format over and over, and so I'll just explain to you. What we've done is we've looked at Sex Now data and looked at by different postal codes and put people into different regions. And so in green, you'll see the data for Vancouver. In orange, you'll see the data for suburban Vancouver and the Fraser Valley, and then you'll see for Vancouver Island, interior and north in the light blue. So if you want to orient yourself to that when we go through. But for this, what you really see is that there's clear difference in terms of spending time with other gay guys around the province, as one might also expect, with it being highest in Vancouver and then under 20% in most other parts of the province. So there's probably many factors that relate to that, but when we look more specifically at social supports and the impact that that has on health, we do see that the proportion of men in Sex Now data who report poor social support is also, there's a gradient by region. So we see that this is lowest in Vancouver, but highest the further away that you get from Vancouver, including in the Fraser Valley, the island, and in the interior and north of British Columbia. So I'm going to just talk a little bit about some of the experiences of marginalization and mental health, and acknowledge very much the work of Olivier Ferlat, who's sort of graciously allowed us to sort of reference this data as part of the presentation. And this was discussed in more detail last year at the summit, if those of you remember. But this is really looking at the syndemic theory, and what Olivier has done is to look in Sex Now data and to apply the syndemic theory, which came out of Ron Stahl and his group in the US, and seeing whether this was also something that we observed in British Columbia, or in Canada, sorry. It was the Canadian data. But the model is starting with so if we think about experiences of marginalization that are due to stigma and discrimination, harassment, physical violence, for example, that these then lead to mental health issues or psychosocial difficulties listed here that then snowball into a syndemic, and that then leads to sexual risk. And so the idea of syndemics is that we have these overlapping epidemics, in this case HIV risk and mental illness as well as marginalization, that all snowball together and contribute. And clearly in Sex Now data we do see this. So in doing this analysis, particularly when you're looking at younger men, we see that younger men at all ages, you do see these experiences of marginalization, with younger men in particular having being more likely to report being feelings of suicidality and harassment, lifetime experiences. And so clearly marginalization and these experiences are prevalent and common to all generations of men. But in focusing on those men men under 30, there is clearly that relationship. So if you remember, the model is from the experiences of marginalization leading to mental health outcomes. And certainly you see that as the number of marginalization experiences increase, we see sort of an increasing gradient in the number of men in sex now who report these various mental health outcomes or psychosocial issues. And then what we see is that men who report more than one or two or three or more of those psychosocial issues have a greater risk of unprotected sex, and risk sex defined as unprotected anal sex with an unknown status partner. So this is evidence, BC evidence, that does really support that link, concrete link between the experiences of marginalization, behavior, and HIV. We've been collaborating with Elizabeth Saywick from the McCreary Center Society and looking at the last 3 rounds of the adolescent health survey data. So this is youth in high schools in British Columbia, and focusing on sexually experienced gay and bisexual male youth or boys in the schools, finding that looking in the data at those who had measures of risk, sexual risk, that protective factors that reduced the risk of HIV included family caring and support, inclusive and safe schools, attitudes of friends and peers, and meaningful extracurricular activities. But in her analysis, she feels that these are protective, but they may not be sufficient to offset the increased risk associated with exposure to physical and sexual abuse, having been in government care, and discrimination on the basis of sexual orientation. So here we have a second analysis of BC data, this time in youth, that again supports that relationship between experiences of marginalization, behavior, and sexual risk. Sexual identity, I'm not going to spend a lot of time talking about this because this has been coming up in other parts. It was discussed in the investigators meeting this morning, and as well I know it will be part of Terry's presentation tomorrow. And we've talked about this at last year's summit as well. But just to acknowledge that there's different behaviors, different prevalence of HIV, different determinants, and they vary by sexual identity. But just to acknowledge that in the Sex Now survey, if we're looking at sexual identity and the proportion of men in different regions who identify as gay, we do see again that there's differences, with men in Vancouver being more likely to self-identify as gay, whereas in other parts of the province it can be between 40 to 70% of people identifying as gay. So there's also some regional differences that we need to think about in terms of service delivery for that. In considering ethnicity, one of the other striking findings that we've noticed when we've just looked at our new diagnoses of HIV in the province of British Columbia is that over the last 4 years, we've noticed an increasing proportion of new diagnoses amongst men who have sex with men of color. And when we look at that by birth cohort, we see some striking differences. So what this shows is that in the men who are in their 30s and under, right now, we have a greater proportion of the new diagnoses in the past 5 years that are amongst men of color. With the most common being Asian, Hispanic, followed by Aboriginal and South Asian. And we see that there is a definite gradient in birth cohorts when we look at the new diagnoses over the past 5 years in terms of ethnicity. This is something that's new for us as well, and so we're trying to understand what some of the reasons for that may be, and I'd certainly welcome your thoughts about that. There was a good demonstration this morning in terms of the relationship between substance use and behavior, and I think that that's still an important point that we need to make when we're thinking about the current epidemic of HIV in BC and the role that substances may play. And again, what you see, and so this is the same kind of template that we'll show again when we're looking at different birth cohorts, with green being those who are 30 and under, to purple being the men who are over 50. And you can see that there's definitely some cohort differences, age differences in terms of substance use, with daily alcohol use being increasing with age, cocaine use, frequent cocaine use, or any cocaine use decreasing with age, poppers being fairly common at all ages and increasing, Viagra being more common in older ages, which probably is a combination of physiologic as well as pleasure factors. So, one of the areas that I think is really important to talk about is access to healthcare. And that's a public health agency determinant of health. It's one that resonates a lot with me and is important when thinking about HIV for gay men. In Sex Now 2011, 40% of men said that they weren't out to their primary care provider. So they're not out to their family doctor or whoever their primary care provider is doesn't know that they have male sex partners. So to me, that's a staggering statistic. However, 85% of men said that they were still satisfied or very satisfied with their healthcare, but about 1 in 7 had ever dropped a healthcare provider because of their negative attitude. When we look at this around the province, we do see, again, differences in terms of being out to your primary care provider by region of the province, with it being highest in Vancouver, and then at around 40% to 50% for the rest of the province. So this is clearly a factor that I think affects gay men's ability to get appropriate health care, and that has implications for HIV as well as many other health conditions that are important for gay men. So now beginning to get a little bit narrower from the broader determinants, focusing in a little bit more, I wanted to talk about sex relationships and networks. So using an example of if we sort of take a theoretical sample of gay men in the province of British Columbia, and then we think about what are all of the different sexual networks that exist. And I've tried to match this as much as possible to some of the Sex Now data, but really the picture is very diverse. So we get men who are not sexually active, we have men who are in single partner relationships. We have men who are potentially in a regular relationship with a partner on the side, to more connected, diverse networks, to men with multiple partners, or sort of more dense networks where there's more sex between partners. And I think this is probably not even a good illustration of the complexity of the networks between gay men in British Columbia. And certainly, if we were to sort of be advancing this over time, we would see this constantly shifting as men enter, exit active networks, or enter into periods where they may be having more frequent partners or maybe not having partners. And I think that it's important to acknowledge that these networks and the formation and dissolution of them, and as people move through them, are important influences on how HIV spreads in the population. And certainly when we look in Sex Now data, and I won't go through each of these in detail, but certainly men report a wide variety of things that they're into at the moment in terms of, and these do sort of correlate to some of those ideas in terms of sexual networks. With younger men, a little bit more into hooking up and dating and having a primary partner compared to older men at the moment. But clearly some similarities, some differences by age around the province. One of the things I really think that's really striking and important to remember is relationships between HIV positive and HIV negative men. So in Sex Now, when looking at the percentage of participants who reported having a primary partner who is of the opposite status, we can see in green for HIV negative men, about 1 in 20 negative men have a primary partner who's HIV positive, and about 50% of HIV positive men reported having a primary partner who's HIV negative. And I think this is really an important thing to remember because we value these relationships. And need to think about things like NPEP or things like that that would be really particularly important for these men. So now focusing a bit more on some of the sort of the traditional things that we look at when we look at HIV trends in terms of sexual behaviors, I think it's always really good to remind ourselves that condom use is still a really common and accepted prevention strategy. So if we look in Sex Now for 2011, we see very little difference by age group when looking at this, but we also see that about over 3/4 of men report using a condom almost every time or all the time with casual partners. So I think that's something that is a positive message and something to think about. What we also see in Sex Now when looking at the last 4 years of data is that when we look at sort of these traditional risk factors, so unprotected anal sex with an unknown status partner, going to a bathhouse, having 10 or more partners, we see very little change over time. And so this is potentially, so we're not seeing any evidence, and this sort of bore out when we looked at it by age group as well, in terms of dramatic changes in behavior over this time period over the last 5 years. So this is one of those factors that appears to be somewhat stable. And this is surprisingly constant throughout the province. So this is looking at men who reported having unprotected anal sex with an unknown status partner or risky sex. And we can see that it's quite consistent around the province. To speak to, though, I think what's really important that we recognize is the role of the risk reduction strategy. So this is data that's a bit dated now. It comes from the Man Count survey, which we did in Vancouver a couple of years ago. But clearly you can see that 92% of men, of negative men, and 86% of positive men use some kind of prevention strategy as a risk reduction measure, as a prevention strategy that didn't always include condoms, including having the same status partner, strategic positioning, beliefs in using low viral load as a prevention strategy. And I think some of these are better than others, but I think these are definitely here to stay. And there's good evidence that these strategies do in fact reduce the risk, even if it's not as good as condom use, consistent condom use. But so I think that these are other strategies that are prevalent and things we need to be thinking about. There's one of the things that we were interested in looking at was risk perception. So in Sex Now, how many of the men in this survey said that they had sex in the last year that risked HIV transmission is how the question was worded. So did they perceive their sex as risky or not? And certainly I think this graph shows two things. So when we're looking in green, these are the men who reported having risk sex, and orange, the men who did not. And so we clearly do see that there's a gradient. So men who are having what we would call risk sex also perceive that the sex that they're having is potentially risky compared to men who don't. But we also see a bit of a gradient over time, with this appearing to decrease a little bit in terms of the likelihood that men perceive that their sex was risky. When we looked at this by birth cohort, here's what we found. So in 2011, looking at risk sex in the past 12 months by the three different groups we looked at, there was very little difference in terms of reporting risk sex. But then when we looked at these men and then looked to see whether they perceived risk, we see a gradient where younger men were more likely to perceive that they had sex which risked HIV transmission in the past year, which was a little bit surprising for me because we often hear about concerns about younger men not essentially having the same perception of risk as older men, and the data, at least from 2011, doesn't seem to support that. So moving on to sort of testing an undiagnosed infection. So we know that nationally in the Canadian estimates are that 19%, this is from 2009, 19% of HIV positive men who have sex with men in the province don't know that they're infected with HIV. I think there's good reason to believe that's a lower statistic for British Columbia. Certainly in an older survey from Victoria, the statistic was 4%. From Vancouver, it was 13%. But what I think, when I first started working at BC CDC and I was hearing these statistics, I always had envisioned that means that there's a pool of people out there who don't know that they're at risk of HIV and they're not testing, and we need to try to get those people tested. And I don't think that's the case for gay men. When we looked at the survey in Vancouver, remember there was 13% of positive guys who didn't know they were HIV positive, which translated to 2.5% of the overall survey sample. But we found that 70% or so had previously tested, and most had recently previously tested. So our thinking at the time is that these undiagnosed infections are men who are between testing episodes. So in a sense, the undiagnosed men will get a diagnosis of HIV when they get an HIV test, and that they're really sort of the first, the crest of the wave of the HIV epidemic as it's passing through the population. So it speaks to me around the importance of not just getting people who haven't tested, but also thinking about how we increase the frequency of testing and making testing more convenient. In another way of looking at this data, we looked in our provincial surveillance data at new cases, new diagnoses of HIV, and looked at the time since their last negative HIV test, and with men who have sex with men in blue at the back. And what you can see clearly is that many men have a very short interval from their last negative test to their first positive test. So these are probably men who are testing frequently or testing regularly and routinely. But we do see there's this sort of like distribution or tail out here to the right, which suggests that there are, for some men, potentially a long gap between tests. And so again, to me, this is evidence that sort of suggests that we do need to think about increasing the frequency of testing as a strategy for increasing diagnosis. However, when we look at testing in general, we see consistent and high levels of testing. So very little difference by birth cohort. We see generally in all ages, we see about 50% of men over time having an HIV test in the past year. But we do see some geographic differences again in British Columbia. So we see that this is highest in Vancouver at about 70%, but then decreases to about 50%, 40% in other parts of the province. So to talk about, to touch base then around community viral load and HIV care, because this certainly has gotten a lot of attention in terms of, for prevention. And this is data that was shared with me by Bob Hogg at the Center for Excellence. And this is data that's looking at the provincial treatment registry in British Columbia and looking at the people on treatment who we know are men who have sex with men. And it's not a perfect. They think that there's a lot of underestimating or not identifying people who are men who have sex with men in the data. But what it shows over time is that if you look at blue, this is showing the percentage of men on treatment every year who have at least one plasma viral load greater than 1,500. And that means that these are people who have an elevated viral load, and this is sort of a marker of a community or population viral load. And what we can see is that after sort of the mid-2000s, we began to see this decrease in viral load over time. So population viral load has been decreasing over time. And so this is probably one of those factors that even up until now has been exerting a bit of a downward influence on the trend. So that we have been seeing some impact as a result of that. What we also see is that in purple, this is showing the CD4 count when men who have sex with men are starting treatment. So the higher the CD4 count when starting treatment means the earlier infection you are. And so we are seeing recently as well, in conjunction with plasma viral loads population viral loads coming down, we're seeing increasing in men starting treatment at an earlier stage of infection. And data looking at this as well, and just in terms of engagement in care or HIV care in Vancouver, where we have some data, is also encouraging. So we had in 2008, 72% of men in the man count survey indicated that who said they were positive were on medication at the time. And most recently, in some of the reporting that's being done for Stop HIV, identifying that 65% of newly diagnosed men who have sex with men are linked to care within 30 days, and that has been an increase. And that also, of all of the men who have sex with men who've been diagnosed since 2003, 63% are currently on antiretroviral therapies and 74% are actively engaged in care. Now, one of the factors that's potentially a unique contributor for gay men is acute HIV infection in comparison to other populations. So acute HIV, and the importance of that for those of you who don't know, is this is the period of infection in the first 6 to 8 weeks after someone becomes infected with HIV. And it's a period when viral loads are very high and people are potentially very infectious to their partners at that time, and they may not know that they have HIV. So one of the reasons why acute HIV is thought to be so important for gay men, sorry, I'll get to that in a sec, but we do know from our evidence in BC, when we've looked at this in our data, that men who have sex with men are more likely to be diagnosed with acute HIV. And last year, 16% of all of our new diagnoses were in men with acute HIV infection. And that's in part because we have a test that's available at some clinics in Vancouver, the pooled NAT testing as part of a study run out of BC CDC, which increases the ability to detect acute infection. But clearly there's a lot of men that are being detected every year very early in infection. The reason that it's thought to be so important for gay men is, again, going back to that concept of network. So if we think about where men are most likely to acquire HIV, we can think that in really active sexual networks or densely connected sexual networks are the men who are probably more likely to get HIV. And so if you think about, in these two sort of sample examples of someone who becomes infected, they have acute infection, they have high viral loads, they're unaware that they're infected. And the thought is that you get these bursts of spread of HIV in these connected networks. And it's one of the features that's sort of unique in terms of just the networks that exist, as well as sort of in combination with the nature of acute HIV infection. That is one of those factors that, again, is sort of have that upward influence in terms of sustaining the epidemic for gay men in British Columbia. Co-infections are important to think about. We've talked about syndemics between experiences of marginalization of mental health and HIV, and there's also the thought around syndemics of STIs and HIV, where sexually transmitted infections can increase someone who's negative their chance of acquiring HIV, but also for someone who's positive to transmit HIV. And so it's important to look at co-infections. When we look at the data for British Columbia, what we do know, is shown in the gray bars, is that there has definitely been an increase in syphilis, as many people know, in the province of British Columbia amongst men who have sex with men. It did decrease a bit in 2010, and now it's on the upswing again. We've sort of increased even further in 2012. The important thing to remember here is that 70% of these cases, at least in 2011, were amongst HIV positive men, and so there's some thought that it's spreading more in networks of positive men who are having sex with each other. But what we do see as well when we look at chlamydia and gonorrhea, we don't really have good data for chlamydia and gonorrhea, but we can look at this in a couple of key clinics. And so when we look at the data from the clinics that we operate at BC CDC, we see fairly stable trends over time in terms of chlamydia and gonorrhea positivity. So there certainly hasn't been an increase, which is encouraging. But again, this is one of those drivers that probably grumbles along and continues to sustain the epidemic. So finally, on this whirlwind tour of influences related to HIV, I think it's really important, now that we're right down at that core of an HIV infection, to just acknowledge the role that HIV prevalence plays in sustaining the epidemic. So when we think about it, there's 5,000 men who have sex with men living with HIV in BC, according to the Public Health Agency estimate. In those surveys we talked about earlier, 14% of men in Victoria, 18% of men in Vancouver, which was even 21% if you look just at residents of the GBRD. So that's 1 in 5 men essentially being HIV positive in the Greater Vancouver region. And there is clearly age differences. We saw that in man count, and we see that in sex now as well, is that as you're aging into that epidemic, your prevalence will increase over time. And so I think it's really important to acknowledge that even if we're just thinking about this hypothetical sample, if 20% of the men are HIV positive, the chances, say, of a young gay man having sex with someone who's HIV positive is much much, much higher than, say, a young straight man who's having the exact same kind of sex or the same kind of risk patterns. And I think that prevalence is really important to acknowledge. And unless we dramatically decrease incidence or dramatically cut off incidence now with heart and lifetime expectancy being as good as it is for people who are positive, this is a factor that will continue to be a driver of the epidemic. So over time, gradually, slowly, the prevalence will continue to increase slightly. And so this will be one of those drivers of the epidemic that we need to think about, or at least acknowledge that that's a factor. In Sex Now, when we look at the proportion of men around the province who report being HIV positive, we do see, again, differences by region, with the prevalence being 20 to 25% in Vancouver, and then dropping to sort of under 15%, sometimes under 5% in other parts of the province. Again, if you remember in the earlier slide, we also showed that there's testing differences between urban and rural areas, and that's probably a factor behind this as well, in terms of testing rates being a bit lower in these areas that have lower prevalence. So that's the sort of the data part of what we've been talking about, and I think it really it leaves us with the question of where do we go from here, and that's partly what we want to be talking about today, is what are some of the strategies we should be thinking about going forward. I'm not trying to be overly simplistic or diminishing by this title, but I think it's really important that we acknowledge that it is complicated. There are many factors that are involved, many drivers that are involved, and that's why the title of the presentation is There's No Magic Bullet. This is a complicated epidemic, and the solutions themselves also have to be complicated. And I think it's really important to acknowledge that the dynamics and influences on transmission in gay men are similar but fundamentally different from other populations affected by HIV in British Columbia. I think, as an epidemiologist, I'm very reductionist, and we look at things in isolation, but these influences don't operate in isolation, as we know. They intersect, they can be additive, and we have clearly seen that they vary by regions of the province. So a solution or program that's good for Vancouver may not be the program that's good for other parts of the province. And I think it's always really a really important message, certainly for me and the people that I'm speaking to, not so much this audience, but recognizing that gay men are not uniform, and there's diverse social and sexual groups that are important to think about when we're thinking about strategies for HIV prevention. And then finally, just to acknowledge this is by no means a comprehensive picture. As I mentioned earlier, there's many things we haven't been able to look at. There's many factors that are potentially influences that we haven't considered. And so that's also part of what we'd be interested in discussing today. So just to acknowledge again, Rick, Terry, and Olivier from CBRC for the Sex Now data, Elizabeth Sawick from the McCreary Center for Adolescent Health Survey, Bob Hogg and Nada Gaderick from the Center for Excellence in terms of the treatment data, and Chris Archibald for providing the data from the Public Health Agency of Canada. Thanks.